All right, I think we should probably get going. Thanks again, everyone, for coming. You have arrived at the webinar, Why Most Therapists Make Anxiety Disorders Worse and What to Do Instead. My name is Dr. Andrea Kulberg. I'm a clinical psychologist here in Santa Barbara, California. I am speaking to you in one of the offices at my private practice, Anxiety Experts of Santa Barbara, and I also run a child and adolescent program here in Santa Barbara, a PHP and IOP for general mental health problems and substance use disorders. Also treated adults in our adult program and have treated both adolescents and adults in many other settings for severe anxiety disorders. And of course, about 1 in 3 to 1 in 4 of those people has a substance use disorder. So just wanted to let you know before I get going with my slides that there will be a question and answer period at the end. So feel free to jot down your questions and then put them in the Q&A box toward the end, and I'll be happy to answer those. Also, there is a poll at the end of the program, so if you would be so kind as to stay around and take the poll real quick before you leave the webinar, that would be very helpful to see for. All right, so let's get going with our slide. Why do therapists often worsen anxiety? Well, the first reason is because they believe that their job is to provide reassurance. Highly anxious people come to us, people who are using substances to medicate their anxiety oftentimes, and we believe that it's our job to reassure them that nothing bad will happen, to provide evidence that their feared outcomes in life won't come true. The problem with that is it supports the illusion of safety or certainty in life. And of course, no one can have either of those things. There is no safety in life. There are dangers all around us. We are all taking all kinds of risks every day when we walk across the street, get into a car, are around environmental toxins or whatever it might be. We have the risk of our feelings being hurt, of being rejected, and there is no certainty that if we avoid the world by substance use or by isolation or whatever, that we will be any more safe or any more, or that we will lower our risk for bad things happening. And so we really, as therapists, need to discontinue providing reassurance to our clients, because over time it grows anxiety rather than lowers it, because there's never enough of it. Another reason why therapists worsen anxiety is because they collude with the notion of getting rid of anxiety. The patient is coming to see you because they want to be rid of anxiety. They believe the lie that if they could only feel less anxious, then they wouldn't be using their substances, or they wouldn't be isolating or whatnot. And it isn't true that anybody can get rid of anxiety. And it turns out that all efforts to rid oneself of anxiety grow it. And the reason for that is because when we brace against or distract from our anxiety, we tell the body and mind that the normal state of anxiety is dangerous and can't be tolerated, which of course is not true. The body can handle any amount of anxiety. Another reason why therapists often worsen anxiety is because they believe the 3 lies that go with anxiety. If you look in the DSM-5, you'll see all the symptoms of anxiety under the panic disorders section. And right after the body sensations of anxiety will be listed the 3 lies that go with anxiety, the 3 thoughts that most often accompany anxiety, which are that it's dangerous, that it will keep rising forever, and that it might drive a person crazy or make them lose their mind. None of which are true, of course. No amount of anxiety is harmful. There's no scientific evidence that anxiety by itself is dangerous in any way. It can't cause a heart attack or stroke or make anyone snap and lose their mind. Of course, we do have patients that lose their mind, but it's not our anxiety patients typically. Anxiety also always has a beginning and a peak and a downward slope. It's always temporary and harmless. So, but when a therapist believes that anxiety can be dangerous, or that it will keep rising and not have a normal beginning, peak, and downward slope, or that it could drive a person over the edge, then how can they possibly teach the patient to manage their anxiety. Another way therapists worsen anxiety is that they believe in the notion of stopping thoughts. So what we find in the clinical research is that all efforts to stop thoughts increase their frequency and intensity. Thought stopping was actually a pop psychological theory that was debunked in the literature decades ago. And so we really want to make sure we're never teaching people thought stopping in psychotherapy. The truth about thoughts is that whatever thoughts you're resisting will persist and increase. And this is because when we tell the mind that certain thoughts are dangerous, by paying more attention to them, by trying to get rid of them, we're paying so much attention to them when we're trying to stop them, that the mind decides that, gosh, that must be very important. And it produces more and more of those thoughts. This is an extremely important concept for the therapist to know and for you to teach all of your patients who cope with anxiety. Another way therapists worsen anxiety is because they get stuck on possible root causes. We have decades of research now that show that it is not helpful to try and be certain about root causes of anyone's anxiety, because it's impossible to know the root cause of anything. And people will spend years in therapy looking for underlying issues and make no behavior change because they never expose themselves to what they fear. So they have no opportunity to learn that their feared outcome won't come true because their therapist talks on and on with them about their history. And we already know from, like I said, extensive research that insight does not bring behavior change. And so in the treatment of anxiety, what you must teach your patient, and what you must understand for yourself, is that the content of the thoughts is irrelevant. That anxiety can get stuck on anything, and it's usually random. It's usually just about whatever is important to the patient, like wanting certainty about the safety of their children, or wanting certainty about whether they will be rejected in social situations, or wanting certainty that they will succeed in a job or in academics. There is no meaning usually to what the person is stuck on, or not one that we can count on anyway. So it isn't that you're not going to take a thorough history and understand any traumatic events that your client might have endured in their life, but because a majority of your patients won't necessarily have a trauma history, you're not going to spend time a bunch of time understanding root causes and trying to get certainty about what the content of the thoughts mean, because that will not help the person accept the content, habituate to the content, and not treat it as dangerous, which is what we need to do in exposure therapy. Another way therapists worsen anxiety is that they're not trained in the #1 treatment for anxiety, which is a form of cognitive behavior therapy called exposure with response prevention. And in case you have not heard of ERP, the exposure part of ERP involves exposing the patient to situations or thoughts or images that produce anxiety. And the response prevention part of ERP involves preventing the usual safety behaviors that the patient uses to try and prevent a feared outcome. So if we are not going to worsen anxiety by all the methods that I previously presented to you, what are we going to do instead? Well, as I mentioned, we're going to do exposure with response prevention therapy. And there are workshops available through the International Obsessive Compulsive Disorders Foundation. And the reason why the OCD Foundation offers these workshops, you can get them for adults, for children, pediatric workshops, adult workshops. The reason why they offer this is because once a practitioner learns to treat obsessive compulsive disorder with exposure therapy, the therapist is equipped to treat the entire anxiety spectrum. The most common thing we treat in mental health is anxiety, so we should be experts in it. Even many people who come to us for depression are really coming to us for feelings of hopelessness about the fact that their anxiety won't go away. And so they would rather take a substance or rather think about exiting the planet than moving toward their anxiety because it is so uncomfortable. So exposure therapy is really the #1 treatment for the entire anxiety spectrum. And if you want to educate yourself, in addition to taking a workshop for ERP, you can read the Bible on Treating Anxiety, which is by Jonathan Abramowitz. called Exposure Therapy for Anxiety, which was published in 2012. He's out of UNC in the Carolinas. So once you learn to treat simple phobias, GAD, agoraphobia, panic disorder, social phobia, and OCD with exposure with response prevention, then you will be fully equipped to treat substance use disorder, because anxiety is the main symptom underlying substance use disorders. Most people with addictions are trying to turn off their thoughts, their anxiety-producing thoughts, or diminish the body sensations of anxiety. So why don't I teach you more about anxiety, since therapists know very little about it, unfortunately. What anxiety is, if you even just read the DSM-5, is anticipation of future threat. So it's about what might happen that you have no evidence for, because no one has a crystal ball, right? So no one can tell what might happen in any moment, on any day. So it's not the same as fear. Fear is about real and present danger. When you are taking a hike and you see a rattlesnake and you have a surge of fear, that is about the real and present threat that is there. Anxiety is about whatever threats might occur that you have no evidence for. So anxiety is a perfectly normal state. Everyone has it. No one gets out of anxiety, and it becomes a disorder when it interferes with your life. The same reason substances become a disorder, right? When they interfere with someone's life, the substance use continues. When they are having all kinds of consequences in their life, negative effects on their relationships, their work, their other important role functioning, then we know it's a disorder. So anxiety is not dangerous, as I said earlier. It is not the same thing as stress. Stress is real life events that build up and can be very even damaging to a person's health, depending on how they perceive the events. So stress is, I lost my job, I got a divorce, I am doing badly in school, there was a fire in our home, those real life events, which is why we might be moved along the anxiety continuum after events like that. Because especially if we perceive they're harmful to our health, the stress can exacerbate what's going on with us. So let me introduce you to a person, if you don't already know about her, the world expert on stress, Kelly McGonigal at Stanford. She wrote the book, The Upside of Stress. If you've ever watched any of her TED Talks, you know that she used to tell people that all stress was harmful to their health, until she started doing these huge longitudinal studies with thousands and thousands of participants, where basically she keeps track of their stressors and then they see how fast the person dies. What she did was looked into moderator variables over the last 20 years. And the biggest moderator variable in what happens to you after war, famine, disease, or various other stresses is whether or not you perceive the stress as harmful to your health. So it's the perception of the thing that determines whether or not even stress is harmful. But of course, that's not the same thing as anxiety, because we have no reason to believe that anxiety is damaging to a person's health. The body is designed to handle intense panic attacks, and no damage occurs whatsoever, right? People go into the emergency room every day saying, I'm having a heart attack, I am having difficulty, I'm going to lose my mind, I'm having a stroke, whatever it is. And they take all their vitals and tell them, you had a panic attack, you can go home now. But of course, it feels very uncomfortable. Anxiety feels so distressing that we're pretty sure we need to escape or leave the situation, go to a doctor immediately, or smoke a joint, drink some alcohol, or take our benzo. I developed late last year an anxiety continuum that I had been drawing for my patients for, the last 15 years on my whiteboard in my office. I decided to incorporate it into some of my talks. I had never written down my anxiety continuum for anyone else before, but here it is. So I started using it in some webinars and conference presentations that I've been doing. The way I see anxiety after 20 years is really on this long continuum of lower than average levels of anxiety on the left and average in the middle. And then the disorders, as we go further and further to the right, with 1 in 10 people having a simple phobia. Again, you can look up any of these prevalence rates in the DSM-5 because it has great statistics on how common the various anxiety disorders are. And then we have generalized anxiety, which is characterized by excessive worry about work or school or other normal things, but which interferes with your functioning, interferes with your sleep usually. And then social phobia, where we have panic attacks in social situations or just surges of anxiety that result in a lot of social avoidance and a lot of thoughts that we're going to be scrutinized for 3 things mainly: our appearance, our words, our behavior, and a lot of exaggerated thinking about that, and catastrophizing and personalization goes with that. And so what might result is agoraphobia, the next thing on our continuum, and or panic disorder that isn't only related to social situations. Then on the continuum, we have obsessions and compulsions that don't take up too much of a person's time, but which are distressing, and they live with a high baseline anxiety. And then we have obsessions and compulsions that take up more than an hour of the person's day, and they meet the criteria for OCD. Down here also on the right-hand side of the continuum is the eating disorder zone, where anorexia and bulimia live. And of course, the status of the research now on severe eating disorders, which I've been treating my entire career, is that anorexia and bulimia are believed to be a different phase of the same disorder that is obsessive compulsive disorder. So that's how we now understand the eating disorders. So we treat them with exposure therapy along with the entire continuum of anxiety disorders on the right here, because that is the #1 treatment for the entire spectrum. And ERP has the largest effect sizes in our field for any treatment for any disorder. So it's very powerful. 70 to 90% reduction, for example, in the symptoms of obsessive compulsive disorder by using exposure therapy to treat it. So let's go over the normal body sensations of anxiety so you can teach your patients not just everything I've said so far, but also this didactic information about anxiety itself. It's really important to teach your patients that the #1 body sensation of anxiety is nausea or stomach upset, sometimes also diarrhea. But a lot of patients will go to their physicians, they will go to see well-meaning alternative health practitioners when they are highly anxious and decide that, oh, it's something I ate, it's something that's medically wrong with me. And of course, a well-meaning practitioner might tell the person, you need to skip gluten, or you need to do this or that. When food allergies like gluten are extremely rare, and 90% of the time, the person is going to see the physician or other health practitioner for anxiety. And they also have racing heart, hot flush, difficulty breathing, or like a choking sensation, trembling or shaking. A lot of tearfulness will come with it. And then some things that feel like neurological symptoms, numbness and tingling in the extremities, derealization, depersonalization, etc. And then, of course, the 3 lies that always accompany anxiety and panic. I'm going to die or be in danger. I'll lose my mind or lose control. I'll snap and do something rash. And this feeling will never end. It'll just keep going up and up and up, which of course never happens. You can think about any time you've been highly anxious about something, and it always goes down on its own. So a panic attack, the definition at the bottom here of this slide, is the catastrophic interpretation of these normal body sensations of anxiety. So when we are perceiving the anxiety as dangerous, when we believe it will make us lose our mind, or when we believe that it will never end, we take it up to panic levels and have a full-blown panic attack that sometimes lands people in the emergency room. So the best news for our patients is that anxiety always has the beginning, the peak, and the downward slope. It's always temporary and harmless. I use that phrase with my patients all the time. And it's a gift to them to let them know that they can't be harmed, that they may as well invite it to peak as quickly as possible. If you get a chance, you can go on YouTube and look up a little video that I show all of my patients called How to Stop a Panic Attack. It has a little cartoon in it named Jane, and unfortunately Jane looks anorexic, sadly. But the reason why, I think his name is Barry McDonough maybe, that made the video, he has a website called panicaway.com, or at least he used to many years ago. The video teaches the patient how to demand that the anxiety peak as quickly as possible. And that's a very important thing to teach your patient, is to observe the body sensations, let them come, invite them to peak as quickly as possible so they can be on the downward slope. Let your patient know that the more they resist the body sensations or brace themselves against the body sensations, the higher they will drive them up. So inviting it to peak is very important. Also, I'm teaching you, and you're going to teach your clients, that anxiety lives on three things. These are the three things that grow anxiety. This is how they got to where they are in the continuum, or maybe they were genetically predisposed to their place on the continuum, which is more likely, right? Genetics is huge in anxiety disorders. OCD, for example, has a 40% concordance rate among identical twins that are raised in different families, right? So if one has it, the other has a 40% chance of having it. So it's a very high genetic load for predisposal to a higher baseline anxiety. So no, your parenting probably didn't cause your social anxiety, the parenting you had. The genetics probably did. However, people can grow their anxiety a lot, and their family members can grow their anxiety a lot if avoidance is allowed, reassurance seeking given, and compulsions or rituals are being engaged in. So we call these safety behaviors. And the reason why we call them that is because they create an illusion of safety or certainty. Because as I said earlier, no one can have either. No one can be safe in this world, and no one can be sure about anything. There's nothing sure. Even the idea that we might wake up tomorrow isn't sure, because any of us could have a brain aneurysm in our sleep. There's no way to know, right? So the three ways that someone makes their own anxiety worse, even worse than their genetic predisposal that they might already have been granted with by their genetics, is through avoidance, reassurance seeking, or rituals or compulsions. So I show this slide in nearly every talk I give. I love to educate clients and therapists about the anxiety cycle because it's so poorly understood. I write this on my whiteboard for every child, adolescent, adult who comes to see me for anxiety, because none of them realize that they are making themselves worse rather than better. And most therapists don't realize that they have been colluding with anxiety in treating people. So the job of the anxiety monster, as I call it, is to bring up what if thoughts. And this happens for everyone, not just people with anxiety disorders. Anxiety brings up what if something bad happens? What if someone I love is harmed? What if I committed a terrible act? What if I made a wrong decision? What if I'm unhealthy? And then it brings a bunch of body sensations on, and the number one of which, of course, is nausea, stomach upset, heart racing, difficulty breathing, hot flush, etc. And then the anxiety wants the person to do something. The person will usually say, I have to do these things that I do in response to my anxiety. They have to avoid something, check something, count something, repeat something, or seek reassurance from someone that this what if, this bad outcome won't occur. The problem is, even though that lowers their anxiety in the moment, because they feel slightly better after having checked something or counted something or avoided a situation or sought reassurance from a loved one or from the internet, they feel better in the moment. However, because that is one of the things that the monster lives on, they fed the monster. And in the long run, the monster will be bigger and louder and bring up more what if thoughts, more what if something bad might happen, higher levels of baseline anxiety, and more demand to do one of the three things that grows the anxiety more, right? The monster wants more of what it lives on. It wants more avoidance, more reassurance seeking, and more rituals or compulsions. And the person complies again to lower the anxiety in the moment, because temporarily they get rid of that discomfort. But of course, they fed the monster again, and the monster is bigger and louder, a much higher frequency and intensity of thoughts that something bad might happen, right? What if I'm unhealthy? Higher levels of anxiety, and then the greater urge to visit more doctors, to do more research about health symptoms on the internet, to avoid more foods, to do more exercise compulsions, or whatever it might be, right? Lowers the anxiety in the moment, but then grows the monster, more thoughts about what if I'm unhealthy, or if the person happens to be stuck on something different, What if I do something to harm someone? What if I made the worst decision of my life in breaking up with that woman or whatever? And then higher levels of anxiety, more demand to enslave oneself to the monster and to the 3 behaviors that make anxiety worse. So the solution, of course, is to not feed the monster. And the formal solution to not feed the monster is to do the exposure with response prevention therapy. You can also see my other 2018 C4 webinar, which has a lot more detail about ERP. But the basic gist is that once you learn your exposure with response prevention therapy, you're going to first teach didactic information about anxiety. You're going to teach the patient everything I taught you so far about anxiety. And then you're going to slowly, hierarchically stop the 3 safety behaviors that drive the anxiety. You're going to discontinue the avoidance with the person. You're going to stop the leaving situations. You're going to help them stop isolating, help them stop using substances. You're going to stop the reassurance-seeking, all right? You're going to make sure that you let the patient know that every time they ask someone else for reassurance, every time they look up something on the internet to try and rule out something bad happening, every time they visit health practitioners, they are making themselves worse and not better. Because there'll never be enough reassurance, right? I had one patient who, had a ton of exams for cancer before I started seeing her. And she was right about to get another exam before when I had our first session. And I said, you can have 10 more exams or 10,000 more exams, and there'll never be enough evidence that you don't have cancer, because you could still have cancer. 2 out of 3 people, or I think it's like 40% of people or something. Or no, I think I looked that up the other day. I want to say it was half of people die from cancer. Anyway, it was a very high number. And you could die from cancer too, I said. And so there's never going to be enough reassurance. There's never going to be enough avoidance of toxins or whatever it is she was doing. There's never going to be enough doctor visits or checking on the internet about symptoms of cancer. You're going to have to discontinue all those things and have the number of physicals, 1 per year that all average people have, and not seek any additional health visits to health practitioners, and see how it turns out. And so exposure therapy was discontinuing all those safety behaviors. And of course, most clients are very resistant to stopping their safety behaviors. Children and adolescents usually have to be incentivized to stop behaviors like school refusal or asking for reassurance, etc., and other social avoidance behaviors. And people with anxiety are help rejecting because they believe this lie that their anxiety is harmful, and they spend their lives trying to avoid the discomfort associated with nausea, heart palpitations, sweating, difficulty breathing, etc. And why wouldn't they? No one has ever told them that it cannot harm them, and that if they move toward it, it will peak and go down more quickly. So when you are teaching the patient about ERP, about anxiety, and how the treatment is going to go, make it clear that you are not trying to get rid of anxiety, because of course no one can have that. The patient is coming to you for the primary reason that I could live, they're going to tell you, if I could just get rid of these thoughts or get rid of my anxiety. And as we have just discussed, no one can get rid of thoughts. That would be like trying to stop the weather. And no one can get rid of anxiety. In fact, all efforts to get rid of it grow it. This is because it's telling the body and mind that a normal state is dangerous, and that sends off more alarms in the body that the anxiety can't be handled and drives it to panic levels. So it's very important that you communicate during the didactic part of the exposure therapy as you're preparing for the live and imaginal exposures themselves, which we'll get more into in a minute, that we're not trying to get rid of anxiety and we're never trying to stop our uncomfortable thoughts. The person with anxiety thinks, I'll just go to therapy. They'll help me get rid of these thoughts and get rid of my anxiety, and then I'll be able to live my life. And nothing could be further than the truth. The only type of treatment that works for anxiety is the opposite, where we help the person embrace their anxiety and move toward it, help them move toward their thoughts. In fact, in ERP, we teach the person to think the thoughts more, the uncomfortable thoughts. If they want to think about anything less, we're going to think about it more. And I'll tell you more about that in a minute too. So we're not trying to get rid of thoughts, and we're not trying to get rid of anxiety, because that will drive both up. So you'll teach your clients to embrace all the body sensations of anxiety while they go on with what they were going to do anyway, even while they're highly anxious. They're going to go on with whatever's meaningful to them in that moment, whether it is continuing to sit through the lecture in their classroom, or continuing to do their job, or continuing to sit in the movie with the person that they care about. Whatever it is, they're going to keep doing what they were going to do anyway until the anxiety peaks and goes down. So what do we actually do with the patient once we have educated them all about anxiety and embracing all the body sensations, and that we're not trying to get rid of it anymore? Well, we develop exposure hierarchies and imaginal exposure scripts. So again, you're going to learn more about this when you read Jonathan Abramowitz's book, Exposure Therapy for Anxiety, or take a workshop on ERP. But I'm just going to go over it briefly. And you can also watch my other webinar, which has a little bit further explanation of ERP treatment techniques. But basically in ERP, there are two types of exposures. One is live exposures, where the person is going into situations on purpose that make them anxious and slowly, hierarchically doing things that are more and more difficult while they invite anxiety to come. So for example, for social situations, if someone has had repeated panic attacks in social situations, on their hierarchy, you would put all the things that might make them anxious: texting people, calling people, organizing an activity at their home, inviting people, going to the gym, the movie theater, a group setting, all of which they might have had panic attacks in before, and all of which they're going to go back in from the very smallest to the most difficult situation while inviting panic. I had a patient who shared at the clinic that I work in yesterday in group that she had been able to do the next item on her hierarchy, which was to go to the gym and invite a panic attack. So she, the first day during the week, had gone and sat outside for an hour and tried to invite panic in her car and couldn't go in. And so the next day she went and sat for 30 minutes in the parking lot and invited a panic attack and still couldn't go in. And then the day before our group, she went, sat in her car for 20 minutes and said, I'm just going to get this over with. I am going to invite the panic to come. And of course, she invited the panic attack to come, went in the door of the gym, and it never came, because in my 20 years of treating people, when someone is inviting a panic attack to happen, it's never happened. And so, but she was willing to have a panic attack, and we all said that maybe she would be the one that had the panic attack. And so she came to group to say that she had successfully done her workout without having a panic attack, even though she was willing to have one come on at any moment, because a panic attack can happen at any moment. And the group had already told her that she might have one. But she was seeking it out, and it didn't happen, and she was shocked to find that it didn't happen. So she determined that she would go to the gym the next day and only allow herself 10 minutes in the car before she went in and did her workout. Again, being willing to invite panic attacks to occur in all the previous situations where she had had panic. So that's an example of a social phobia exposure hierarchy. But of course, you could be treating the person for anything. So live exposures might include going into stores, exposing yourself to foods, exposing yourself to contaminants, exposing yourself to body sensations of anxiety. So in a session this week, earlier this week, with a patient I have that has obsessive compulsive disorder and has a long history of abusing benzodiazepines, which she has entirely weaned off of now. We were inviting body sensations of anxiety by breathing through a straw, doing interoceptive exposures, by spinning her in a chair to get dizzy and nauseous, by hyperventilating on purpose, breathing through a paper bag, different things to invite body sensations that mimic a panic attack, and say to ourselves, maybe we'll throw up, maybe not, there's no way to know, and see how it turns out, okay? So a lot of times we're just habituating to body sensations in live exposures. And then, of course, another type of live exposure is to reduce compulsive checking, counting, repeating things to extinction. So one of my patients right now who checks his gas, his water, his door locks, etc., before he leaves the home to try and create the illusion that the home will be safe while he's gone, even though, of course, it could burn down at any time, or he could be robbed at any time, despite locking the doors 10 times or 10,000 times, as I always say. So he has been hierarchically decreasing his checking while inviting anxiety and even panic level body sensations when he leaves the home. And again, he just decreases the number of checking. First, he checks his, I think it's 3 times in multiples of 3, so everything 9 times before he leaves the house. For a week, he just decreases it to 8 times. And then when that feels easy, then he decreases it to 7 times, etc. So that eventually he is turning everything off once: his shower, his coffee maker, his stove, and locks the door once and leaves the house while agreeing with thoughts that it may burn down, that he can't be sure, that there will be no safety in life, and that he's not going to throw his life away to checking, counting, repeating things when it brings him absolutely no closer to certainty that he will be safe, or that his dog or relatives will be safe. So those are live exposures. So 2 parts to each live exposure. One is going into the situation on purpose that makes you anxious, or decreasing the compulsion on purpose, or repeating or counting while you agree with thoughts that something bad may happen. And imaginal exposure is the second type of major exposure that we do in ERP. Imaginal exposures involve inviting thoughts on purpose or images that are disturbing, okay? So we write a script of all the most terrible, horrible thoughts that the person can think of related to whatever their anxiety is stuck on. Maybe they're stuck on health. Maybe they're stuck on dying. Maybe they are stuck on fears that they will make the wrong choice about their future. I have one patient right now who is stuck on getting certainty as to whether or not there is any meaning to life. He's a philosophy major, very bright man in a graduate program, and he spends hours and hours all day thinking about whether or not nihilism might be true. And so we wrote a huge, long imaginal exposure script this week where he is embracing all of his most terrible thoughts about what if there is no meaning to life, what if everything is for nothing, and all of his relationships, all of his efforts to make a difference in the world are for nothing, and there really is no meaning, and his entire life is a facade. What if these thoughts torment him for the rest of his life, and he is unable to tolerate the extreme anxiety that this causes and ultimately kills himself? What if he dies a lonely death in an institution and never sees anyone that he cares about, etc.? So he is going to be reading that script over and over and over in a single sitting each day, observing how his anxiety peaks, and then he's going to stop reading it when the anxiety comes down by about half the peak level. And again, these are imaginal exposure techniques that you learn when you go to an exposure therapy training workshop or read about exposure therapy in one of the books that I suggested. So what this does, this script writing, is it reduces mental compulsions, which are review of past memories, recitation of safe thoughts, or just efforts to answer a question. Anything that a patient comes to you and is trying to figure out for sure the answer to a question, what if I become an axe murderer? What if I'm gay? What if I die from cancer? What if I have thoughts or images that are disturbing to me and I can't get rid of them? The treatment is the imaginal exposure scripts for that. And oftentimes patients will read the imaginal exposure script into a recording app on their phone and then listen to it on their headphones for 20 to 60 minutes a day, or until their anxiety peaks and comes down, like I said, by about half the peak level. Another few reminders about exposure procedures, if I haven't mentioned them already, is that they should always be graduated and repeated. So we're doing an exposure many times over. So if a child is refusing school and is very uncomfortable in the classroom setting, they're going to be required to stay in the classroom for longer and longer periods. Once staying in there for a couple hours is easy and they're earning their incentives, the things they care about most, maybe it's their Xbox, maybe it's access to their phone, maybe it's getting to participate in a play maybe their thing is theater, maybe they care about contact with their friends, maybe they care about a certain hobby or interest, and they're going to do these exposures when they're being incentivized because they are earning the things that they care about, and they're going to do the lowest thing on their hierarchy for many days until that's easy, and then you're going to make it harder and increase to the next most difficult thing. And you do this with adults too. This can be done in residential treatment. It can be done in outpatient treatment, where you are creating exposure hierarchies for any behavior you're trying to intervene with, and they're going to do one of those things or two of those things till it's easy, and then continue to move up the hierarchy, taking it up a notch. Also, you're going to have them order the exposures on their hierarchy, or you can do it when you make it with them, by how much distress the exposures cause. So the SUD scale, the subjective units of distress scale, is used in exposure therapy all the time, either 1 to 10 or 1 to 100 scale, where the patient is rating how much distress they expect to experience while they're doing that exposure. Then they see whether they were accurate or not. But you're kind of putting them on a gradient ahead of time so that you don't move too quickly and the patient doesn't get discouraged in the exposure therapy treatment. So you're just generating a lot of feared thoughts and situations and having them rate them, and then you're putting them into either a hierarchy if it's live exposures, or into a exposure script if you're doing imaginal exposures. The other thing to do with exposure therapy is to involve the family, if at all possible. I treat a lot of young adults in substance abuse treatment at my clinic and in my outpatient practice, and I also treat a lot of adolescents. So I always involve the family in not providing reassurance, not rescuing the person from their anxiety, not accommodating the individual, and this is a huge help in the treatment process in the exposure therapy. So in case you're wondering what I'm talking about in terms of accommodation pitfalls, these are things where family members decrease their loved one's distress by yielding to their demands, pleasing them to avoid a reaction, facilitating their avoidance behaviors, but allowing the person to, bringing them home from college when they're socially anxious, or allowing them to avoid other people, places, or objects, or participating in their rituals, buying extra cleaning products or special foods or whatever if they're avoiding certain foods, or if they are using a lot of hand sanitizer or whatnot to alleviate anxiety. Assisting with or completing tasks that their loved one can complete for themselves, or decreasing their loved one's responsibilities in the home. None of that is going to help the person with anxiety. So you have to train the family members to withdraw all of those accommodation behaviors, not provide verbal reassurance that nothing bad will happen, because no one can predict when bad things will happen. And so why would we promise a loved one that nothing bad will happen? Another thing parents do with adolescents a lot is physically touch them when they're distressed and anxious. And of course, there's nothing wrong with physical touch in families, but it's just that when a person is anxious, it takes away from them being able to deal with the anxiety themselves if they're receiving a lot of physical touch. So instead of accommodating, we're going to tell the family members, and us as therapists are going to not accommodate. We're going to not provide verbal reassurance either. Instead of doing that, we're going to say, I see that you're anxious. This will be very uncomfortable, or this looks like it's hard for you. And then we're going to make statements and tell the family to make statements that invite the person to embrace uncertainty. So we'll say things like, you know, maybe that'll happen, maybe not. We can't be sure. There are no guarantees in life. There's no way to predict the future. We don't have a crystal ball. You could even say something like, you could avoid that right now, but you will be making your anxiety worse, and I hate for you to feed the monster. A patient came to see me the other night who had severe social phobia and was having a panic attack when I think he's 18. I was talking to him and his parents in my office for the very first time. And suddenly I could see his face flush and that he was having a panic attack as we were talking about what exposure therapy is. And he was imagining going into situations while he's highly anxious. I was just giving the basics about exposure therapy and why it's the opposite of what anyone would think that would work for anxiety. And so he said, can I go to the bathroom? Can I just take a break and just take a moment to calm down outside? And I said, you could do that. However, it will make your anxiety worse for the next time you come into my office. You could instead just choose to sit with your anxiety and we'll just go on with what we're doing, talking, and you can let it peak while you're here in the office since it can't hurt you. But it will be uncomfortable for you to stay in here. So I understand if you choose to leave. But if I encourage you to do that, I'll be making your anxiety worse instead of better. So he stayed in the office, and it was the very first time that he was able to tolerate a panic attack and not leave the situation, not lay down, not smoke a joint, which is what he had been doing for his anxiety. And he learned that very night that he could tolerate panic and not have to do anything about it, that it would last 10 to 15 minutes like all panic attacks do, and that if he didn't do any avoidance behaviors, he wouldn't jack it up and make it worse for the next time and send the message to his body and mind that it was dangerous. And so I won him over that night by helping him see that there is no amount of anxiety that can be dangerous to the body or mind. And that was a great gift to him. So statements that embrace uncertainty encourage a person to staying with their anxiety and invite it to intensify so that it will peak more quickly and not engage in safety behaviors. So books for you or for family members would be things like Chomsky's book, Freeing Your Child from Anxiety. Very good book on exposure techniques for families to use, for therapists to use. Of course, if you have any patients with OCD, you would have them read Freedom from Obsessive Compulsive Disorder and Read It Yourself by Jonathan Grayson. Families really benefit from When a Family Member Has OCD by Jonathan Hirschfield. And then, of course, you yourself would read Exposure Therapy for Anxiety by Abramowitz. Another great book for patients is the Phobia and Anxiety Workbook, which is on Amazon. I forget the author of that, but it's a very famous anxiety researcher. I think actually Ted Beck might be the second author on that. So Aaron Beck, the godfather of cognitive behavior therapy, whose daughter, Judith Beck, can't remember her name. She is carrying on his legacy there at University of Pennsylvania and teaching exposure therapy to everyone who will come take her workshops. So I think Aaron Beck is now in his 90s and won't be with us too much longer. So of course there are many disciples that are going ahead and carrying on cognitive behavior therapy for depression, which is what Beck developed CBT for, right? It also helps some with anxiety, but I only use it about 20% of the time and use exposure therapy 80% of the time because that is what works best for anxiety. CBT used alone tends to function as reassurance because you're usually weighing the evidence for certain thoughts and there's never enough evidence for severe anxiety disorders. It has to be that the person lives with not having certainty in order to have freedom in living with anxiety. All right, so that's the main slides that I had for you guys. I just want to open it up for a few questions and answers now. And then of course you guys can stay for the poll if you don't mind. I think I clicked the Q&A button, so hopefully, oh, here it comes. I just didn't click it and press down thoroughly. I'm not seeing any questions in the Q&A bar right now. But if you have anything on your mind, go ahead and type it in. Oh, here we go. Is there a population or patient that would not be appropriate for ERP? Yes, of course. If you are treating someone with depression who is displaying symptoms of inappropriate guilt, suicidal thoughts, a lot of worthlessness, hopelessness, a desire to hurt themselves, etc., that would not be the appropriate time to use ERP. There are instances wherein someone will come to you talking about death and dying, and they are afraid that they might hurt themselves or afraid that they might harm someone else, that kind of stuff. That is related to anxiety. But if you are treating true depression with depressed mood, all the other signs of clinical depression, ERP would not be indicated. The number one treatment for depression is CBT, classic cognitive behavior therapy, not exposure therapy. So good question. And next, will we have access to your slides? Of course. Anybody who wishes to download the slides from the C4 website, they are up there. So are my slides from my previous webinar earlier this year. So of course, I want you to have access to any of this information. What would be a good workshop to attend to get started? My favorite workshops on the treatment of anxiety are through the International OCD Foundation at iocdf.org. They are they have the Behavior Therapy Training Institute, the BTTI courses. And when you learn to treat obsessive compulsive disorder and get really well versed in exposure therapy, you learn to treat the entire anxiety spectrum, which of course is the #1 problem underlying substance use disorders. What kind of resistance do you get from other therapists or families, and how do you respond? You know, that is such a good question. I do have a lot of colleagues that feel that exposure therapy is a harsh model. And again, what I say is do you want to do what works, or do you want to do what makes the patient comfortable and will continue to grow their anxiety? And so you're making the patient more uncomfortable in the short run with exposure therapy. This is why I teach the patient too. You're having more anxiety now in order to have less later. And so the way I respond to it is, do you want to keep living into a smaller and smaller box? Because what you're doing now isn't working. Continuing in your avoidance behaviors and in seeking reassurance and in using your substances is going to continue to make you worse. And you know, what is the life you want? I sometimes combine a little bit of acceptance and commitment therapy when I'm having trouble getting buy-in to ERP, because I'll do a values card sort with the person. I'll discuss, you know, what is the life you are going for? What would be meaningful to you to accomplish while you are here in your short time on this planet? And is your avoidance behavior, reassurance-seeking and compulsions helping you get there, or is it not? Will you probably have to move toward the things you fear the most in order to get the life you want? And will it be worth it to you to not have your top value as avoidance of discomfort or the illusion of certainty? Because it's only an illusion. You're not creating any more safety for yourself. You do not get to have the thing that none of the rest of us get to have, which is certainty about anything or safety in this life. If you want to go around continuing to grow that illusion, okay, but I don't think you're going to create any enjoyment or happiness for yourself. Lastly, last question, how do you address the person's buy-in to their rationale for using reassurance or overthinking? Let me see if I can reread that and understand the question better. How do you address the person's buy-in? I guess it's just to continue to reiterate to the person that they're not going to have the certainty that they seek. They are not going to be able to get the safety that they seek. And do they want to continue to throw their life away to trying to stamp out doubt. People with anxiety are plagued by doubt. Did I make the wrong decision? Did I turn off the stove? Did I run someone over with my car? Will I be rejected in this social setting? Will I have a panic attack when I go on this date? And the answer to the question is there's no way to know. You may be in danger or have panic or be rejected or be in pain at any time. All we can do is move toward the anxiety, the body sensations, move toward the thoughts, accept the thoughts, let them be there, invite them in to stay because they're going to come and go anyway. Let them be present, and then do what you care about. Do the things that are going to take you toward what's meaningful to you anyway, even while you're highly anxious, because that's the only thing that will create the opportunity for the anxiety to go down, right? When I fly off my horse and land in the dirt when I'm jumping, cantering around, jumping, and my trainer, who is like a therapist, tells me to get back on, and I say, no, I think that was too high for me. I think I should try this again another day. I think that I could break my neck. And she'll say, yep, all of those things are true, and now get back on the horse. And she doesn't make me go over the jump one time. She makes me go over it 10 times. And each time I go over it, guess what? My anxiety goes from 10 to 9 to 8 to 7. And eventually I am saying woohoo over the jumps because of repeated exposure to my anxiety. I have the opportunity to learn that my feared outcome is not as likely to come true as I thought, that I didn't fall and break my neck, even though I still could, right? Every time I arrive at the barn and get on a horse, I know that I could end up paralyzed. But I would rather do what's meaningful to me and what I care about than avoiding what I want to do in order to lower but not eliminate the possibility of danger or distress. All right, guys, so good to be with you all. I hope you'll take the poll, and please email me. My email is amkulberg@msn.com. If you have any questions about your patients or ERP, love to consult with you about a case or give you a referral where you live. I see patients at Anxiety Experts here all over Colorado and California because I'm licensed in both states, and we do live video here at my practice. So we can offer, even in rural areas in those two states, live video. But if you need a referral where you live, or you have questions about training and exposure therapy so you can turn your practice upside down and be the superstar in treating severe anxiety and substance use, then please contact me and I'll give you advice on that. All right. Good night. Good afternoon, everyone. Take care.